I'm not Florian, apologies, it's the second year I've not been Florian. I'm going to talk a little bit about symptom management. I apologise if I make some sweeping assumptions about your local team's paediatricians. There are some really, really good local teams and paediatricians. I think sometimes they're not, and that's not their own fault, it's the fact that they're just not exposed to a lot of the things that we see. So I'm just going to talk a little bit about symptom management and why it's really important, because I think this is what we hear. Leukodystrophies are rare, so therefore you are scary, unknown, and best left to the specialist. I think it's a really long time since one of my children has gone to their GP and their GP has actually provided a treatment. But actually, what are the things that you go to your GP or your local team with? Reflux, vomiting, constipation, irritability, poor sleep, feeding difficulties, dystonia, spasticity, visual impairment, tremor, seizures, startle. So some of those are neurological. They're not all neurological, and most of them are really, really common. So actually, yes, seizures are not really common, but startle is common, reflux is common, constipation. 1 in 3 children have constipation. So just because you come with a pile of other stuff doesn't mean that we can't think about the basic bits and how we manage those. You just need somebody to listen and to understand and think about, for your child or for your patient, why is that bit happening there? Because we need to understand the why before we can think about the how do we sort it out. Oh, and I had spasm, forgot about that one. Oh, and pain, sorry. So this is just taken from Tuesday's clinic, so it doesn't, you can usually ask me most weeks and I can find a story that is relevant. But I've seen a little boy he's now 2.5 years, and he was diagnosed with a mitochondrial leukodystrophy on the day after his first birthday. So he had completely normal development, he got tonsillitis on his first birthday, and within that week he had lost all of his skills. And he hasn't regained those skills, so we've been looking after him now for 18 months with huge amounts of difficulty. So he's got long-standing dystonia, he's got long-standing constipation, he has long-standing regression and loss of those motor skills. Oh, this is not, sorry, I should have had some clicky things in it. Oh, there we go. But newer onset seizures earlier this year. In the first 12 months of his diagnosis, I probably saw this family every 2 weeks, every 3 weeks, and if not, in person on the phone. So we had loads of really regular contact. And that's because actually his brain was evolving and his clinical symptoms were evolving at that time rate. And yes, I can rely on a history over the phone or the examination of somebody else, but it's so important to know what I'm treating, because otherwise I give you the wrong medicine and we do the wrong thing. So he'd had recently been taken under the palliative care team, who are excellent, and I'd actually had less contact probably over the last 4 to 6 months. I'd seen the odd video, I knew some things were seizures, some things weren't seizures, and I'd given a little bit of advice, but actually he was mainly under the palliative care team. And that weekend before he'd come in to see us, he'd had a symptom management stay because things had been difficult. So I saw family in clinic. This is a family I have to evict from clinic quite regularly because they always overstay their welcome, but in a positive way. But they were last, because otherwise we run late for the rest of the day. But essentially, having had a really difficult 18 months, and I know that because I've been through lots of it with them, this last 6 weeks had been their worst 6 weeks in all of that period. He was irritable, he was crying, he didn't sleep, and he just has his clonidine put up, so he's on a clonidine patch for his tone, and he'd gone into Martin House, our hospice, and had 4 times a day oral clonidine added on top of it. His tone was the best I've ever seen his tone. His tone was fabulous. He was still crying, irritable. Mum couldn't put him down, or in this movement constantly, and it was this, or it was crying in distress. They were his 2 periods of life. And I'm seeing a lot of rocking similar to that over here this week at the moment. So he was treated for dystonia. He's had dystonia, he has dystonia, he's had long-term problematic dystonia. So we've just treated his dystonia. His dystonia is good today. I don't know what it looked like last week, but today it was really good and the best I've seen it. But actually, when you go through the story, he goes to bed at night, he falls asleep. Within half an hour, he wakes up, and when he wakes up from sleep, without fail, he's having some funny leg kicking, not sure what it is, that doesn't look like seizure, and some funny eye movements that I'm fairly sure is seizure. He settles relatively quickly, goes back to sleep. He wakes up half an hour again later, same thing happens. He wakes up, he has some movements that are seizure, some movements are seizure. He cries, he's then distressed. His crying leads to distress, that leads to stiffness. So he is dystonic, but the dystonic isn't the thing that happens first in that story. There's a whole cycle, and they do this all night. Then he gets up in the morning, tolerates his morning feed, but by lunchtime he's done, and the rest of the afternoon through to bedtime is awful. And that's his 24 hours, and has been his 24 hours for the last 6 weeks. You need to know that story to know where we are. So my assumption is, I think he's probably having more seizures. Since we've introduced his seizure medicine, he's on an anti-seizure medicine earlier, we've put it up a few times, so he's on a good, he's not a top dose, but actually, he probably hasn't got better when we've done that. We've put a medicine in, but it hasn't changed how things are. So now I think he's having lots of seizures in sleep. He's then having poor sleep. He is fatigued, he's irritable, and he just feels foul. He can't communicate that. So then he's crying, and when he cries, he gets dystonic and stiff. So what we've done is treated this bit. That is okay, and the medicine he's on actually is a little bit of an irritability medicine, so it does, but we haven't fixed the rest of it. So we need to think about where your symptom lies. So yes, they were clear, this was dystonia, they got the right symptom, but where does it lie in your 24 hours and what causes it? Because I can give him all the sedatives in the world, and it doesn't fix the start of that problem. So I've changed his I only saw him on Tuesday, we've changed his anti-epilepsy medicines, I've arranged some extra tests. I'm not a tester, but I think actually it would be better. I need to understand a little bit more about his nighttime, and then we'll see what happens. So I'm going to ring them in 2 weeks' time and see where we are. Because actually, he also has really significant constipation and his bowels are a problem. I think he takes too much Movicol, which is a softener and a bit of a stimulant, but he doesn't have a proper stimulant. And I think there's probably a combination of two things. I don't really want to do both of those things at once, because if I do both of those things at once, I don't know where we are. So we've made a plan. I've moved his clonidine into his patch. I don't want to give him 4 times a daily dose of clonidine that makes him sleepy. Treats his tone, but makes him sleepy. I want to give him more of that medicine that's an irritability medicine as well through 24 hours. So reduce his daytime sleepiness. This is the ideal. It might not work, and that's really important to acknowledge. But reduce his daytime sedation, improve his 24-hour sedation, irritability, comfort medicine, and then treat his seizures, which I think is probably the thing that has changed. In 18 months of complication, this 6 weeks, I think, is probably his seizures. But review him in 2 weeks' time with a bit more information from a test and a changed medicine, because actually there's probably another 4 things I could do, but let's work out where we are then. Without doing that, you will never get the right mix of medicines. Now, I might think I've got the right mix of medicines, they don't work. There's no guarantee having the right mix works at the end of the day, but if you never start at the right starting point, we're never going to get there. So I'm just going to quickly talk about symptoms, so groups of symptoms. It's not a medical management talk, but talk about some of the challenges we have and how you as parents and families can try and think about the things that you say so we get to the right decision and discussion. Now, Hannah comes to my clinic with me every time, and she's been our nurse specialist for a couple of years now, but before that she was a ward nurse, so she knows neurology really well, patients really well, but actually the digging deep into how we talk about symptoms is trickier. And my clinic, we do a, when did you get up? What does this look? And we talk through your 24 hours, because I don't believe that without understanding your day, I can understand your symptoms. So GI symptoms in all leukodystrophies to some degree are problematic, because the things that you see in your muscles on the outside are what is happening to your gut on the inside. Your gut is made of muscles from the top end through to the bottom end. There is a real difference between stomach things that are upper GI, so do you have that reflux, vomiting, feed intolerance, through to lower GI, so your constipation. And I need to understand not just that you have GI symptoms, but where are those symptoms? When do they come in your day? And then how can I do that? So I think in almost all of our patients, so dystonia patients particularly, but even our children with spasticity usually have some complications with their bowels. You probably need to have some degree of prophylactic management. So there's not many patients that aren't on something that helps their bowels go a little bit. You might only have it every other day, 3 times a week, but it's better to prevent those problems than get to them. There are medicines that do the upper GI stuff. There's reflux medicines, there's prokinetics that push things through, and then there's a combination of constipation management, and we have a really good gastro consultant who has taught me a lot of things. I've learned new things this year, having done this for a long time, about the combination of medicines and we should be looking. So there are, the most commonly prescribed bowel medicine is lactulose, which I think is the devil food because it makes you really bloated before it does anything to your bowels. So if you're already driven by discomfort, giving you more discomfort on the way to trying to fix a problem just makes things worse. Movicol is a really good medicine. It doesn't fit for everybody. it softens things, there's a bit of push, but you probably need something else that gives you a bit of push. And there's all of those things to think about. So what is it? Where in your GI system is it happening? And what are the choices of the medicines that I can give to try and fix that problem for you? Medicine 1 might not work, and sometimes I don't know on the outside, so you have to try to start somewhere. But you need to have regular review. If you change something and 6 months later ask them how it went, I heard yesterday how chaotic everyone's lives is. 6 months later, you don't know how it went. And that's okay, because you can't. So you have to then break it down and go again. That's the role of our nurses and our specialists and your care coordinators, to have that more regular contact. Now, tone. So tone is a really non-specific word, but the other words people might use is stiffness, spasticity, hypertonia, dystonia. But there is a difference in different types of tone, and then the drug choices I use for those different types of tone are important. And they're different. So spasticity is where you have some stiffness all the time in all your movements. So you always have, and the typical child with spasticity in a non-leukodystrophy setting is children with cerebral palsy that get that scissoring of their legs or might have stiffness in one side of their body. That is usually spasticity. There is always a degree of stiffness there. Now I can move it in certain ways, so if you do a bit of fast movement, slow movement, you can get past it a little bit, but there's always some spasticity. Dystonia is that movement and tone and stiffness that goes up and down. So some days you're really floppy, or sometimes you're really floppy, sometimes you're really stiff. It's really trigger-driven. So I want to understand, what is it? What do you look like on a good day, or a good hour within a day? And when do you look bad? And are you bad just on your own? So you have a bit where you just are stiffer, or are you triggered, and is it reactive? So do you have a reactive dystonia? If I poke you, you become stiff. If I don't poke you, you're not stiff. What's the trigger in that? Because actually, all of the medicines I use for tone are going to relax your muscles, but they're not just going to relax this muscle and this muscle, they're going to relax all of these muscles. So for children, adults, where you are still doing some of this head control, this swallow, some of your sitting, so things that are really good for your health in terms of your lung health, your general nutrition, if I make you really floppy in the middle because you're a bit stiff on the outside, that is a big problem. So I can make things worse before I make them better. And stiffness on its own isn't always a problem. So if you are a little bit stiff, and I'm paraphrasing on terms, but it's not causing you pain, it's not causing you discomfort, you can still sit in your chair, you can still stand in your standing frame, you can still get dressed without difficulty, that's okay. I don't need to treat it all, and often it looks worse on the outside than sometimes it feels for the patients, because the consequence of me treating it all is never free. There's usually some form of side effect, so you have to balance yes, I want to treat that bit of tone because that means you can't get dressed in the morning, but actually those are the bits that you are worried about. I'm acknowledging them, but I'm not treating them, because if I treat those bits, I'm going to accelerate or change something else in the picture. And it's always better to treat triggers. So like our case in a little boy, I can treat the stiffness. But actually, if I miss the trigger, I'm just sedating him. I'm making him floppier everywhere. And that's not the right mix of medicines. And we need to think about the associated difficulties. So for spasticity, there's one medicine that is probably the first choice for most people with spasticity. It tends to make you a bit floppier in the middle. But if you've got spasticity, that's still the best medicine, and we have to balance it. For dystonia, there's a bigger choice of drugs, but some of them are really good for dystonia and pain. Some of them are really good for dystonia and dribbling. So if I'm going to choose a medicine, surely choose the medicine that fixes as many problems as possible without adding more medicines in. And remember to review and change. It's really easy to add medicines in, to increase medicines along the way, and then never take them away again. So if that medicine isn't working for you, we need to remember to be able to take it out as well. Tone's trickier. Epilepsy, I see patients in my epilepsy clinic, there are 5 drugs. They've been on 5 drugs for 8 years, and what are any of them doing at this point in time? We've got no idea. So we have to remember, when we do drug tests, we test one drug against another drug and say, yeah, they work okay together. We do not test it where we throw 8 drugs into your child and go, okay, that's okay now. So you are the test case for that. So we need to be trying to reduce polypharmacy, because actually some of the things that upset your children and your patients day to day might be our fault, and we haven't realised that because we're trying to manage this, but we've caused that. Sleep. I heard a lot about sleep yesterday, and next year we're probably going to do a sleep session, because actually we've realised that would be really useful. But there is a difference about when you don't sleep, or when your child or your partner doesn't sleep. Why is that? Is it because they don't fall asleep? Is it because they don't stay asleep? And then what wakes them? What happens first? So they wake up, Are they stiff when they wake up? Or are they waking up, then something happens, their tummy is grumbling, they're thrashing their legs, GI discomfort or bladder, but then they're upset, then they're stiff. So which is the first step in that? And then how often does it happen? How long is it? How difficult is it to settle them? Because then we're pitching, I could sedate you all, but that's not always, it's easier, but it's not the right option. So actually, which bits are we treating? Which bits are we not treating? What are we going to tolerate? So for sleep, we always need to start with the removing the triggers. So think about the triggers, remove the triggers, change the environment. All those sleep hygiene things that I, as an adult, I did not sleep when I was pregnant. Someone told me and I nodded at them. But it is important to change the environment. We can't expect our children to sleep in an environment that is not conducive to sleep. Their brains are fighting fire all day just to be not stiff, alert, look around. And if you put them in the wrong environment for sleep, their sleep-wake cycle is not the same. They won't have those sleep indicators, so then they won't be able to achieve it. So we have to do those things first. We can think about hormone measures, so things like melatonin, I'm sure people have heard of or may be taking. That is a sleep hormone that tells you it is bedtime. It doesn't sedate you, it's not a sedative, it doesn't keep you asleep. It just tells the body it's time to go to sleep. So if you're falling asleep, that's a really good medicine. It's a natural hormone medicine. We should be trying that first. We can give short release, we can give long release, we can sometimes give a second dose, but it's not a sedative, so it's not going to overcome all of your sleep problems. And then we can use sedation, and there is so much worry about sedating children, I think in particular, but often, if we don't manage your sleep, you're then foul in the day, and then you don't tolerate your feeds, so then I give you some really strong medicines that sedate you all the time. So actually, let's just sedate you to sleep. It's okay. If we're going to sedate you in your 24-hour period, being sedated at night time isn't the worst thing to do, because at least if we can, I'd like you to have natural sleep, but if I can't get there, actually if I give you sedated sleep, I might not have to sedate you so much in the daytime, so we might get something, all of the aim is quality of life, and I don't know how much good wakeful hours I can give you, but I know if I sedate you 24/7, that will impact some of that to some degree. And even if you're not asleep, if I make you fuzzy, then you probably feel foul, and it takes away some of the quality and the value. People talked yesterday about actually being allowed and encouraged to live life. Well, yeah, because your children have a neurodisability doesn't mean that you don't have all of those other bits that are really important, and protecting the good bits by treating the bad bits right is important. Now, very quickly, because I've got no idea how long I've got left. Abnormal movements. So I'm not going to go into loads of detail because these aren't relevant for all of our patients. Now, someone talked yesterday about startle and how startle can be confused in AGS for seizure, but there's lots of funny things that kids with tone do, kids with seizures do, and kids with just neurodevelopment do. So there is a spectrum of abnormal movements that we see, some of which I'm worried about, most of which I'm not worried about, but for me to be able to counsel and reassure you and talk to you about them, I need to understand what they are. So as parents, what are they? When do they happen? Are they triggered? Can you distract them? Are they stoppable? And actually, are they troublesome? So there are things I know are seizures, but if you flicker your eyes for 3 seconds every 4 hours, that's okay with me, because it's about quality. And the degree of medicine I would need to switch that off, I've got co-presenter over here who's doing my work for me now, is probably not worth the benefits you get from me making your eyes not flicker for 3 seconds every 4 hours. So there is balance, but you can make an educated choice and discussion once you know where you are and what you're treating. Now, I'm not, as I said, I don't do tons of tests. I don't do EEGs or brainwave testing on all of my patients because you have enough hospital appointments, frankly, and so most of the stuff I would treat clinically. If I can understand it, we'll treat it, we'll see where we get, but we have to be confident enough to say, if I might be wrong, there's lots of things I don't know what they are, and if you're not getting somewhere by treating it clinically, changing a medicine, then you have to revisit and say, actually, do I need more things and more information? And I'd say in the first instance, that's probably going to be videos. I would want everything videoing, and then we may do more tests going down the line. So how can you help? Neurologists don't know everything, definitely, but actually you deal with not just neurologists, you deal with physios, GPs, therapy staff, schools, and they definitely aren't going to be able to tell you about everything, never mind someone that's experienced and does it on a day-to-day basis. I don't want you to label things. You don't need to come into my clinic and say, the constipation's awful, the dystonia is awful, but tell me what it is. So be an expert observer. Don't feel the pressure to label it, but do think about what's happening, when's it happening, that 24-hour diary. Don't kill yourself with diaries. I've got some families that break their A4 textbook out every time they come and see me in clinic. And actually, all I want you to be able to do is say, this is a this week problem, or this is a every single week problem. This always happens then, so a pattern recognition. I feel very sorry with people that bring it and they go, oh, look at all this paper. And you think, I'm never going to read all of this paper, because actually it's the trend and what happened yesterday. If it's never happened before, I don't want to treat it. I want to see what happens next week. So it's about that pattern over time and the impact on your life. Videoing things if relevant. If you're not sure, take a video. We'll see if we can work it out together. And then it's okay not to know. As parents, so my family in clinic on Tuesday, they were just at the end of their tether, and the guilt you feel because you don't know what bit you need to do. I mean, I don't know what bit we need to do. We've made a plan that I think it seems sensible, but in 2 weeks we might revisit that plan. I might not be regularly not right, but I might not be right. So I don't know, that's okay. It's okay as parents for you not to know, but it's just, if you can know when the impact, that's okay. You don't need to know everything, and we just need to be able to revisit things. And you as parents can be confident to say, let's try one thing at once to your paediatrician. Okay, this seems sensible. Let's try that first, and then we'll do this. When are you going to revisit that? So you can advocate, but you don't need to be diagnosing it all, because I was told yesterday, you're all care coordinators, you're all expert managers, you're all admin assistants and secretaries, so don't try it. You don't need another thing for you to do, but make sure you've got a team that is able to revisit, recapitulate, and you can advocate for that. So our take-home messages. Neurologists don't know everything, and that's even the best ones, of which I'm definitely not one of those, but I do a lot of leukodystrophy. Observe the signs, the patterns, and the process, because only once we understand that bit can we have a punt at getting the right treatments. Empower your local teams to break it down. Don't listen when they say, well, it's too complicated, I'm just going to send you to a specialist that you'll wait 3 weeks to see. Actually, no. It's probably quite simple. You just need to break it down. And if you break it down, you can probably get somewhere that gives you a sensible plan A while you're waiting for plan B and C to come along the way. Think about it. Try treatments. Have the confidence. All your community paediatricians will regularly prescribe tone medicines. So it's okay to start a tone medicine or to change a tone medicine, but they need to have thought about the first bits of why they're doing it and what they're treating and the pattern of what they're treating before they do that. And they need to have a plan to review it at the end to see if it was the right change or not. And then monitor that progress. Don't be afraid to restart, to reset, to go again, and acknowledge that you were wrong first time round, but now you're going to try and get it right. That is okay. I don't know how long I spoke for, sorry. Thank you very much. Any questions? Was I too long?
No, it's perfect.
Okay.
Thank you very much. That was so good, so clear, I think really good direction. I know personally when, Cameron was young, I think sometimes that sort of, your child's got a leukodystrophy. I don't know leukodystrophy, but actually, as Dr. Green said, your local doctors know how to treat tone. They know how to treat dystonia. So it's kind of getting them, to sort of say to them, look, you do know how to treat this, because you can't always see the specialist really, really quickly. Now, I'm sure you're all quite happy to have a break now, so we'll do a quick Slido and Dr.
Are we doing any questions and answers? Is any questions in the room?
Shall we?
I think there's no questions in the
No
room. Everyone's
questions
heard
in
me
the
talk
room.
enough.
We've got a couple of questions online.
Okay.
Is it working now? Okay. So, it's me working now, so it's going
You guys are welcome to wander if you don't want to stay.
Okay, so what is being done to better understand cerebellar ataxia in leukodystrophies? This is my child's most prominent movement disorder and cause of not being mobile.
So I will be honest, in terms of specifically what's been doing from a research perspective in terms of cerebellar ataxia and leukodystrophy, I'm not aware of anything. That doesn't mean it's not happening, I don't know about that. I think, again, cerebellar ataxia is not an uncommon problem across a lot of neurological problems. So it's whether you try, not everything has to be labelled in leukodystrophy at the end of it. It's actually thinking about just your cerebellar ataxia. Now, ataxia is a really tricky symptom to treat. It's about core strength, stability, having the right equipment. There are researchers, we met with a researcher just before Christmas who's looking at ataxia generally, so understanding the assessment processes, the use of AI and technology, so can we understand, so there is research in ataxia more generally going on, but that's often years off coming into a patient cohort and group, but there is always research in the background. It's just how it's implementable to your child at the moment. If you think about ataxia more generally, it's about, I always attribute it to imagine being your wobbly toddler. So they're not as strong on the inside, the head's a bit big for the body, so they're not quite skeletally built in proportion yet. But actually, the reason toddler wobbliness gets better is two things. They get maturity in their brain, so their tracts myelinate, their myelin is involved in that, so they myelinate, but also they become stronger. So actually, you can't fix the myelin bits, but you can talk about core strength to some degree within your own abilities. And so there are some things you can strengthen and protect or provide equipment for that makes some of the other bits a bit easier.
And the next question is, a physiotherapist has noticed some new hand trembling when going the mobilising standing frame connected to excitedness. The same when self-propelling in the wheelchair. Any advice?
So I think video it. So I think there's loads of things that, and particularly if it's connected to excitement. So there are behavioural movements that are normal, expected, seen in well children, but seen much more frequently in children that have other neurodevelopmental problems that I'm completely not worried about. It may be something to do with that. And there are other things related to tone, because you get excited, you get a little bit more stiff, your tremor comes out a little bit more. And again, I'm not necessarily worried about that, but you might think about treating some of those bits of it if it then causes other trouble. So they need to video it, think about where they happen, and then take it to someone who's going to examine you with that and say, actually, I think it's because of this bit, and either we're worried or we're not worried. You can't do over something like this, but you can get more information to find out.
And the last question is, you mentioned lactulose. What about enemas?
So lactulose is just sugar syrup that makes you bloated. Enemas are part of that bottom end. So there are stimulants that you take from the top end and stimulate all of you got all the way through. There are stimulants just from the bottom end. Not all my patients will be on an enema or a supplement. Some of them are, never in isolation. You need a softener with them. Sometimes I give a stimulant from the top end with a softener from the top end. Every patient is different. I would never use an enema daily, or I very, very rarely use them more than, they tend to be my backup. So we do two things first and then you have an enema, but some of my patients have them 2-3 times a week because it just treats it in a different way. And for some patients, that's what you need. So it's just part of a big picture. Thank you. Now you can go. Thank you very much.
Thank you, Lydia.